you, Tom, and thank you for the opportunity to talk with you about care abroad. A lot of people call it medical tourism. I hate that term. If I'm going to be a tourist, I don't want to go have a hip replacement and then try to enjoy the culture of the country. So I tend to call it care abroad. I tend to call the employee the patient, or the dependent the patient. But to give you a little perspective and background, I tell folks I'm a recovering hospital administrator. I've been in hospital administration for, and y'all can do the math, and I don't mind, and managed care organizations for a little over 40 years. So I've been part of the problem. When I was in health administration, we were some of the best at upcoding, at rearranging diagnosis sequence to maximize DRG reimbursements. We used the same talking points that folks are still using today, 40 years later. Well, we have to charge more because of uncompensated care. We have to charge more because of standby cost. And I'm like, come on guys, y'all been me too, been doing this for 40 years. Come up with something different, come up with something new. Even if it's not true, do something new. Don't keep regurgitating the same old stuff, or change. I know how painful that can be. Change, do something different. But Sky Medicus, and when I joined Sky Medicus, let me back up. When I was asked to be a co-founder of HMO Georgia, which was a managed care company of Blue Cross Blue Shield of Georgia, wholly owned subsidiary. So we had pretty much free reign. We decided we're going to create a very concise network of very high quality healthcare providers in the state of Georgia. That worked really, really well until marketing got involved. They would come and say, we've got a 600 employee group that's ready to sign. However, the CEO's son-in-law is the head of an orthopedic practice. They have to be in the network. I'm sorry, the son-in-law's orthopedic practice was not a good practice. But in order to get the 600 employees, yep, they became part of the network. And so it grew and grew and grew. By the time I left, I think we had probably 94% of all the physicians in the state of Georgia as part of our network. That means we've got some really good providers in there and some really, really bad ones. But we are telling our clients we have a good quality network. We're lying to them. With Sky Medicus, we don't have those pressures. And we are truly creating a network of healthcare providers that are absolutely top of the line. Many of them were trained in the United States, medical school, residency, and chose to go back to their home country to practice. We know that we're in a situation now where it's really up to those of us in this room to begin making some changes. The healthcare cost, over $19,000 per employee per year, is simply unsustainable. We can't keep going this way. We've got to do something different. Personal bankruptcies, medical cost are one of the primary reasons for medical bankruptcy. So why is this? How did we get here? Many years ago, and I hate to keep talking about the past, but I mean many, many years ago, Huey Reinhardt, who is a health economist at Princeton, was speaking to the American Hospital Association annual convention in Chicago. His comment was not very well received, but he had clear documentation. He said, health systems in other countries are established to provide care to the patient. Health systems in the USA are established by hospitals, physicians, and pharmaceutical companies for their own benefit. Somebody's missing. Somebody's missing. And that somebody is the patient and the payer. A solution is medical care abroad. And obviously it's the practice of traveling outside the country. Cost savings range between 40 and 80% compared to the cost of the same care here. And we're seeing a huge, rapid increase in care abroad. And these are only estimates because there is no credible repository to collect this data. So these are simply estimates. This was put out by Deloitte. We are working with the ministers of health and ministers of tourism in all of the countries where we have providers to help them design systems to capture the data and the economic impact of medical travel to their particular country. So over time, we will begin getting some information that is credible. But for now, we have to deal with the estimates. Who is Sky Medicus? We're a HIPAA-compliant medical travel care abroad company. We have proprietary technology that enables us to interface between patients and healthcare providers. We have a private network of providers that are very thoroughly credentialed, and we coordinate all aspects of the care, supporting the patient's transfer of clinical records. And surprisingly, it still surprises me, a lot of patients say, well, I really want to go to wherever for my care, but I really hate to ask my doctor to send my clinical records because he's going to think I don't like him anymore. That's fine, we'll do it. I don't mind calling a doctor. Doctors have called me a lot of things, so turnabout's fair pay. We arrange the flights, we arrange all the transportation, the hotels. We go through a very detailed orientation that I'll get, a credentialing program that I'll get into a little later. But one thing that we have found is that employers who have implemented care abroad as a part of their benefit option are beginning to be looked at as a magnet for really top quality employees. Case in point, we have a small independent college in South Georgia that was competing with Florida State University for a professor that they really wanted to bring on staff. Florida State has a little bit bigger budget, so the issue was salary. So when it came down to it, the professor, the candidate professor, really looked in depth at what Florida State offered and what LaGrange College offered. He subsequently, at a lower salary, accepted the offer from LaGrange College. His comment was, I did that because it was very obvious that you all are forward-thinking and innovative. And if I need, or my family needs medical care, I can avoid the $4,000 deductible by traveling abroad. So he saw that as a potential salary increase if he needed it. So it's really an opportunity for employers to set themselves apart from other employers who do not have care abroad as an option. Credentialing. This is probably my biggest passion. We go through in great detail the qualifications of every medical center and every physician. And we don't want every physician. And just because a physician in El Salvador is not part of our network does not mean that they're not a good physician. It just means we don't need them at this point. I want 2 or 3, maybe 4 specialists in each area. But I don't need 100. I need the top, the best. We go through a primary source verification of every document we collect. We verify with the medical school, their medical degree. We verify their residency, internship, residency, fellowship, etc. When we get to the clinical facilities, all of our medical centers are JCI, Joint Commission International accredited. We go through a mini JCI accreditation, even though they're already accredited. If a medical center has a hospital-acquired infection rate greater than 2%, then we don't even have a discussion with them. They've got to be below 2%. CDC in July of last year put out a report saying that the average hospital-acquired infection rate, hospitals in the United States, range between 5% and 10%. Now, I'm sure there's some that are less than that. Those that are less than 2%, we would consider in our network. We've got the hospital that we use in El Salvador, Hospital Diagnostico. For the last 3 years, their hospital-acquired infection rate has been at or below 0.1%. Hospital facility we use in Slovakia has not had a single reported hospital-acquired infection in the last 2 years. 3 weeks ago now, I guess it was, we were at the World Healthcare Congress in Washington, D.C. We had a full-day medical travel track. Tom was gracious enough to come and participate on the panel. But the representative from the University of Navarra Medical Center in Navarra, Spain, I think Pamplona, running of the bulls, Beautiful, beautiful city. He made the comment, and I didn't know where he was going with this. I was kind of taking deep breaths. He said, we were the second hospital in all of Europe to be accredited by the JCI. We were the first in Pamplona, or in Spain, to be accredited. He said, then Tom comes, and I personally do all of the site visits of the medical centers, primarily because of my background, but primarily because I enjoy being with those folks because of their commitment and their passion. But Alonzo made the comment, he said, after JCI interviews, he said, Tom comes in, and he said, we have never been through anything like that. He said, he would walk into the nursing stations and just start talking to people. And he said, I didn't know what he was talking about. And I told him later, I said, I really wasn't talking about anything. I just wanted to confirm that you had told us the truth, that most of your staff was fluent in English. That's a threshold requirement. The other thing that I did, and I'm really bad about doing this, we had talked about the emergency power system. And they've got a very good system. They're up to full load on their generator in less than 40 seconds. The battery backup will barely allow a blink in the critical areas, the operating room, the intensive care, et cetera. So as we were touring the hospital, we came to the engineering area where the power comes in. So the chief engineer was with us, and I said, how often do you test the emergency power system? He said, about every 60 to 90 days. I said, when did you last test it? He said, about a month and a half ago. I said, great, pull the breaker. And it got real quiet, everybody stood there. And Alonzo said, well, Tom, we've not had time to tell the OR people that we were going to test the emergency power system. I said, that's great, that's perfect. Does the power company tell you when you're about to lose power? How much notice do they give you? What if a storm comes through? The other thing that we do different than JCI, and when I was in hospital administration, I loved it. Joint Commission would always let me know anywhere from 6 to 9 months in advance before they were going to come. Trust me, everything was perfect when they came. Had they come 30 days early, folks, we would have been in trouble. We do not tell the hospitals when we're coming back for recredentialing. And during the medical travel track that we did at the World Congress, one of the executives with JCI came up and said, we had talked about doing that, but what happens if the senior executives are not in the hospital when you do the accreditation visit? I said, what happens if a patient is admitted to the hospital and the senior executives are not there? Does it matter? No. I'm not looking at what the senior executives are going to tell me. I'm looking at what's going on, what's really happening in that facility. Okay, I'm going to change up just a little bit here. Going back to LaGrange College, we had a faculty member, she was a clinical psychologist, who had what had been diagnosed as a precancerous mass in her left breast, huge. She had gotten a quote from the hospital in LaGrange and the hospital in Tallahassee of somewhere between $17,000 and $18,500. She decided that she would like to go abroad for care. We got a quote, and this is not special pricing, this is everyday pricing. And it was such a large mass that she was going to have reconstructive surgery following the removal of the mass. But they were talking about scheduling her to come back for the reconstructive surgery and have another surgery 2 to 3 months later. She went to El Salvador, took her companion with her, actually took her fiance with her, who was really excited. He said, oh, great, this can be our honeymoon. I just kind of stepped away and let them have a little private time because that was the wrong answer. They did get married, so that's the good news. But she was able to go down there and have one surgery because the plastic surgeon got involved once the mass was removed and did everything he needed to do. So single surgery, total cost, $6,970. She saved the $4,000 deductible that she would have experienced and had a fabulous experience. She came back and she said, I'm a clinical psychologist. She said, I know how to explain things to people. I know how to interview people. She said the surgeon, the day before surgery, spent over 30 minutes with me, walking me through everything he was going to do, what I could expect following surgery, the next day, the day after that. And she said, but he did one more thing. He would stop occasionally and say, now, Stephanie, tell me what you think I just shared with you. And she said, yeah, most of the time I got it right. But said a couple of times, he said, no, I didn't think you completely understood that. How many of you, raise your hands, how many of you know a surgeon that would sit the day before surgery for over 30 minutes and talk to a patient to be sure they knew exactly what was going to happen? I'm glad we've got one. I don't know of any. But the communication and the compassion that I see, that's why I enjoy so much working with these guys. And I can tell you right now, as a potential patient at some point, I'm going to probably need surgery. I hope not. But at my age, I probably will. I just am thankful every day when I wake up that I'm on the right side of the grass. But if I do have to have surgery, it will occur outside the United States. It will occur at one of our participating providers. That's how much confidence I have in them, and that's how much I respect what they're doing. The cost is phenomenal. You're looking at knee replacements, $13,000, $12,000. Total hips for $13, $14. And interestingly, in most places outside the country, they are, for total hips, they're not doing the posterior approach. They're using the anterior approach, slightly lateral, so they can avoid some of the nerves that create a longer recovery period. They are literally have those patients up walking day of, not next day or the day after. They're walking the day of surgery. Coronary bypass. A lot of people think, oh gosh, you know, that's an emergency procedure. No, the stent's the emergency procedure. I've had both. When I had my heart attack, I was in the cath lab within 3 hours. Stent was put in. I did the bypass 2.5 months later. The cost in Atlanta, Georgia, this was almost 10 years ago now, was about $121,000. Hadn't changed a lot, but Costa Rica, El Salvador, Mexico, you're looking at around anywhere from $20,000 to $24,000. Those are significant savings. The other thing that we find abroad that is really interesting is procedures that are not available in the United States. There's one that is very prominent. It's called the Wellex procedure. Wellex procedure is a minimally invasive outpatient procedure. You literally walk out pain-free with a Band-Aid. It totally eliminates any discussion about a spinal fusion. There's no need for a spinal fusion. Use the Wellex procedure. It's available in every country in the world except the United States. Cost of that is about $14,000. And we just heard what the cost of a spinal fusion in the United States, even at the great facilities that are cognizant of cost. Alternative procedures for cancer. We've got an oncologist in Germany that does not use any chemotherapy. He uses totally, primarily Laetrile, vitamin C, etc., massive IV infusions over a 12 to 14 day period. His remission rate overall is 83%. The cost of that for the 14-day treatment, not including travel cost, is $7,000. Folks, patients spend almost that much every month on chemotherapy. This patient that he shared with me, this was done 8 years ago now, not through us. I wasn't there 8 years ago, but 8 years ago, and the patient's still doing fine. When the patient went to him, she had just been told by the oncologist at Beth Israel that needed to get the family involved and get hospice in. She was a 29-year-old female, double mastectomy, been on chemotherapy and radiation for about 2 years, and found Dr. Schilling on her own. She said, 29 years old, I'm not ready to go. So she made the arrangements on her own and went. And that was 8 years ago. She is totally cancer-free today. So those procedures do work. The other that is really, really interesting, stem cell therapy. There are clinical trials that are literally just beginning in the United States for stem cell therapy. They've been doing it in other countries for 10, 12, 15 years. Parkinson's disease, multiple sclerosis, diabetes, and the outcomes are phenomenal. Ease of implementation. Employers, we work with them. We have a ERISA compliant benefit plan amendment that can be filed with your stop-loss carrier. To date, we've not had a single stop-loss carrier that did not love it. We've got a number of employers who have put this in that have seen the results literally almost immediately. The employees love it because they can avoid the deductible and they get to travel. Now, that said, you're going to have a couple of employees, I've got one right now, that really needs, and his employer really needs for him to get engaged with us. But he is petrified of flying. He cannot tolerate the thought of getting in an airplane. So it's not going to work for everybody. The other thing you have to do as an employer and benefit advisor is use a little bit of reason. Got a patient that is demanding a tubal ligation abroad because she wants the deductible waived and the travel covered. Tubal ligation where she lives is about $1,200, $1,300. Tubal ligation in Costa Rica, El Salvador is about $600. But depending on your city of origin, for the most part, you can add around anywhere from $2,500 to $3,500 for any procedure, for the travel, hotel, etc. So it doesn't make sense. You know, $2,500 plus her procedure of $400. I mean, you're almost double what she can have it done locally. Now, yes, she's going to have to pay for it through her deductible, but when it does work, it works great. When it doesn't work, sometimes you run into some issues. The first thing people say is it safe? We use NationMaster, which is a website that compares incidences per 1,000 population between different countries. For the most part, you're safer outside the United States than you are here. Literally, pick a country. Now, I live in Atlanta, Georgia. I consider Atlanta to be a relatively safe city. But there are areas in Atlanta that I know not to go. I wouldn't even go to certain areas during the daytime. That is no different in any country, any city you go to. So we tell patients, listen to the provider, the hotel, and the concierge service. We provide concierge service for every patient. Somebody is with them and available to them the entire time they're in country. It's especially important. In addition to the credentialing of the healthcare providers, we also credential hotels and the tour operators. Be sure they speak English, to be sure hotels can accommodate special diets, to be sure they have walk-in showers. That's not really an issue in Mexico, Latin America, Central America. Walk-in showers is a real problem in Europe. They are so proud. And can you imagine a hip replacement in the hotel trying to get in and out of a bathtub? I mean, that's an issue waiting to happen. The hotels in Europe, and all of the hotels we use, a 4 and 5 star, are really proud of their garden tubs with jacuzzis. I told the hotel manager in Pamplona, Spain, I think it kind of offended him a little bit. He was talking about this, and it was a big garden tub. And I told him, I said, look, I was raised in rural middle Georgia on a farm. We would have called that thing a swimming pool. I mean, how much water does it take to wash? So, but we are very cognizant of those issues with every patient we work with. Return flights, if it's an orthopedic procedure, they have to have bulkhead aisle. Many of the airlines, and I will call them by name, Delta and American, are excellent at working with us on that. They have even called passengers that had already booked that seat to see if they would agree to change. They have also, if the bulkhead aisle in first class had not been booked, they would move the patient to that seat at no additional charge. Most of the airlines, Southwest does not have reserved seats, but they will reserve a seat for an orthopedic patient coming back. They'll just take it out of service. One airline, I won't name them, that starts with a U, does not work very well with us, so we try to put the patient on a different airline. But I urge you to consider care abroad as an option for your health plan. I'm available if you'd like to get more information. I've got thumb drives back there that has basically the presentation on it that you saw this morning, along with some other information. And I've got about 4 packs of Salvadorian coffee samples back there, if they're still there, you can't see. But one of our orthopedic surgeons in El Salvador, his family owns a coffee plantation. They're the second largest exporter of coffee. And these came from that plantation. It's at the 6,000 foot elevation level, and the higher the elevation, the more robust the coffee. So if there's any left back there, take advantage of it. Thank you.